The upper and lower jaws, it's their development that establishes how well we're going to breathe.
Welcome to Talking About Kids. I'm your host, R. Bradley Snyder, researcher, activist, and author of The 5 Simple Truths of Raising Kids. You know, I get excited when I learn about new or innovative ways to address any of the many adversities that kids face. But I get more excited when I learn about ways to prevent adversities from occurring in the first place. In a previous episode of Talking About Kids, a guest and I discussed sleep apnea in children, its terrible consequences, how to treat it, and how it often results from a child having an underdeveloped jaw. In this episode, my guest, Ben Miraglia, and I do a more in-depth examination of the consequences of underdeveloped jaws in children, which include everything from crooked teeth to chronic pain, and we discuss how to prevent these problems from ever occurring. Ben is the Chief Clinical Officer at Toothpillow. Ben brings more than his 2 decades of experience to that role. As you will hear, he brings a passion and an intellectual curiosity that I hope you will find as engaging as I do. Talking About Kids is sponsored in part by the Arizona Department of Health Services Must Stop Bullying campaign through its Title V Maternal and Child Health Program. For more information, go to muststopbullying.org. Professionals like Ben have successful practices and are popular speakers at conferences and conventions. So why did he come on Talking About Kids? He came on to further spread information and insights that benefit all children. You can do your part by liking this episode and sharing it with your friends and colleagues. And now, the interview.
The history is that I am a general dentist, but I started in dentistry 31 years ago. And I spent a decade fixing teeth. I did the crowns and the bridges and the implants, and I was a tooth fixer for a very long time. And that's a good component of dentistry. It's a needed component of dentistry. I'm not saying it's a bad thing to do that. But about 10 years of watching then the kind of traditional orthodontic model, where kids got braces from 12 to 14. Braces from 12 to 14, I'm watching the results and seeing the kind of pattern of what goes on. And then you see extractions being done, teeth taken out. And then you're wondering, wait, is this the best there is? Is there any other opportunity to treat these kids? Because 12 to 14, it's not looking so successful. Then, of course, if you're the general dentist, then you send the kids for braces. They come back, you watch them a little bit. They never wear their retainer. So teenagers and college students, not very good timing to wear a retainer every night. But when you don't wear the retainer, the teeth shift back.
Right.
So now you're doing the math. I'm like, well, wait a second. We invest all this time and energy and money into making those teeth straight. But if we don't wear our retainer, they shift back at a very alarming rate. Almost all kids, most, without a retainer. So this seems to be very temporary, like a temporary. So you start to take courses. So I start taking courses. And then you learn, well, there's a whole other opportunity, but it's in kind of the expansive orthodontic kind of realm versus the retractive orthodontic realm. Now, there's a tooth-focused approach, then there's a foundation-focused approach. So braces are a tooth-focused approach, so it happens 12 to 14 is about the age. But the foundation, meaning the jaws, the foundation or jaw-focused approach begins earlier, and it can begin as young as 3. So from 3 to 11, we have this wonderful opportunity to intervene, but that intervention is in a kind of treat the cause category, not treat the symptom category. So teeth are the symptom. Braces treat the symptom late. Whereas if you focus on the jaws and you treat them earlier, well, now you're working in the cause earlier. It's a much
Mm,
more productive and stable and rewarding outcome to grow the jaws early. And when you do address the jaws early and grow them early, the teeth tend to go where they belong. So you grow the right size foundation, the teeth go where they belong, you need less later. I won't say you don't need braces,
right.
but there's a percentage of kids who never need braces. Then the ones who do, they need it for a short time. So you could turn 12 years old and have all the jaw growth early and your teeth are really close to where they belong. You could get a little fine tuning. That's a few months in braces, not 2, 3 years. Much more stable too. So this got going out of, I think I would say it was a displeasure of
Hmm.
seeing the traditional model in what I concluded was this is a failure. And I had it too. I had braces for 3 years. I had the headgear thing. I lost my retainer, teeth shifted right back. Then
Right.
you have to do it again and again and again. So I lived the failure. Then I'm watching it in multiple times. I'm seeing, yeah, this is not adding up. Pursue the education. But then once you learn these things, you start treating the kids. And so we started treating, and then one thing led to another. And of course, now it's been 20 years. So over 2 decades, there's a lot that's been learned, and I'm happy to
Yeah.
be on this call to talk about it.
It's fascinating because, well, first of all, listeners of the Talking About Kids podcast know that we're all about upstream solutions. Like we do not like having to deal with, we like prevention, not response whenever we can. So I'm really
Yeah.
excited to hear that shift in your thinking. When I was preparing for this and I was looking for other data, there was a term that came up, and it's up on a lot of public-facing websites, including sites like from Stanford and things, and that's the term of malacclusion. So as we mentioned right before we started recording, that can be a scary term. So first of all, explain what malacclusion is, and then let's talk about its prevalence.
Yes. So, yeah, malocclusion is the professional word.
Okay,
Broken down, it simply means bad bite.
got it.
So, malocclusion, bad bite. However, if we're in a dental setting with professionals, we usually say that word. But when we're talking with patients in the public, we might use bad bite, but we also use underdeveloped jaws,
Okay.
smaller jaw size. Basically, the underdeveloped jaws are what give you your crowded teeth and bad bite.
Mm,
So most Western industrialized nations have a very high rate of malocclusion or crowded teeth and a bad bite.
okay.
And so there is a point in time when you go back, there's wonderful research out there. Anthropology research is where this all kind of lands. But anthropology research teaches us that a few hundred years ago, malocclusion or crowded teeth and bad bites didn't really exist in the human population.
Right.
Very minimal evidence. Very few skulls have ever been unearthed prior to a few hundred years ago where all of a sudden they have these, bad bites. Now,
Mm,
going back, they start to do the research and they have the skulls to investigate going back by generation. But then the anthropologists do an interesting thing. They start studying isolated, natural, aboriginal, native cultures where there's no industrial or Western influence. And what they learn is that the breastfeeding is followed by hard food early. So it turns out between 6 and 9 months old is when an infant starts to gain control of their head and
right.
also be able to grab and bring to the mouth. So those are the two things that kind of coincide with being able to do some feeding. So somewhere between 6 and 9 months old. Now the breastfeeding is extended in cultures that are pre-industrial, pre-Western. There's a little bit of an extension of the breastfeeding, but it's more important. It's actually the transition from hard food into hard food,
Right.
and so the infant will be gnawing on things that are natural, meaning whatever was grown, whatever was caught. There's very little cooking. There's no processing. There's
Right.
no blending. There's no pureeing. So all of a sudden you have a textured diet that's rougher. Well, the tougher diet early makes your muscles work harder. When your muscles of the jaw work harder, your bones grow better. When the bones grow better, your teeth all go to place. So pre-industrial, pre-Western cultures have fully developed skulls with 32 teeth most of the time. And they're well aligned. They have a good occlusion or bite, good bite.
Right.
Well, introduce softer foods. Now, a few hundred years ago, we get this process started, but then it picks up rapidly. So, if we think about our country, we're like 7 or 8 generations into industrial Western living. This is going back a while now. A generation could be 20 to 25 years. The moment a culture starts to trade, That's where the anthropology notices the shift. A
Okay.
culture that's going to graduate to Western industrial living. So you're going from natural or Aboriginal isolated living, you're going to make your way to industrial Western model. Well, it's a baby step process. It's not an instant light switch. Well, the baby steps begin with, they notice it's food trade. The culture starts to trade for food, and then the preserving, processing, cooking, and
Yeah.
then softening of the food begins. With the softening of the food, they recognize, okay, following the skulls over the generations and the people, the malacclusion rate increases. Now we've got crowded teeth and bad bites.
Right.
Then, of course, they track it over time. In the first generation, it's 50%. Like it jumps to 50% in just one generation.
Wow.
So 20 to 25 years of having an early softer food for an infant can switch the malacclusion rate to very high. So near 0 to 50%. But then each generation it climbs, which is why today you think about the kids we look at.
Mm.
And we can look at it two ways. Almost all the kids we look at are going to need some form of intervention, braces, when they're 12. They won't be able to have their teeth come in perfectly, and they certainly won't be able to fit their wisdom teeth, have 32. That's very rare. So if you think about the rarity of a child that will grow up, have all of their teeth go to place. They're 12 years old, they need no braces. It's a really good bite and well aligned teeth. But then they turn 18 and their wisdom teeth come in, they have all 32. That is a unicorn today. Because that's a
Right.
unicorn, what it means is the rest of the population, aside from that unicorn, has a malocclusion, whether it's mild, moderate, or severe. So if you can't fit all 32 teeth and there's some crowding or some part of a bad bite, you have malocclusion, you've got a bad bite.
Hmm.
However, the end result is that the teeth in the bite you're seeing are the symptom. The real cause is the jaws are small, and we get the smaller jaws from the weaker muscles from the early soft food. So I like to give parents an analogy. It's like going to the gym.
Hmm.
So we know what it takes to build the musculature. So if you haven't been to the gym in a long time and you show up, you get yourself a trainer and you spend a year with a trainer and you can go as often as you need, it's going to be spectacular. We all know a year in the gym with a trainer, I'm going to walk out of there amazing. You're
Right.
very happy, right? Okay. But here's what happens. The analogy is that that's what breastfeeding and hard food do during that first year of life. Now, 12 months, we've got breastfeeding, we've got hard food. There's your training for the muscles. So your jaws are grown beautifully. But let's say after 12 months of this beautiful process, we switch to soft food. Well, here comes the analogy. If you step out of the gym after 12 months, everybody pretty much knows you cannot keep that physique without upkeep.
Right.
If you go back to your normal life, no more gym, no more trainer, it's going to fade. And it can fade rather quickly. Here's a bigger fade. If you were to leave the gym after 12 months of work, you've got this incredible physique. Most people understand if you had some sort of illness or disease or accident where you were bedridden for 2 weeks, if you had to lay in a bed for 2 to 3 weeks, you'd lose that entire physique. The muscle would be gone.
Right.
Well, that's what 2 to 3 weeks of soft food does. It only takes 2 to 3 weeks to lose the musculature and lose the
Oh,
jaw growth.
wow.
So, like, even if we did it right for 12 months, and I'm not here to tell anyone that I did anything right, my children all had bottles and pacifiers and soft food. We did everything wrong. And then when they were teenagers, they told us we did a lot more things wrong because then the teenagers know how many wrong
Right.
things you're doing because
Right.
the teenagers know everything. So they pointed out a lot more things I was doing wrong. It was very educational for me to learn how many things I was doing wrong. So, but my kids are now older. They're 24, 23, 18. But we did it all wrong then. And I intervened early. I did intervene when they were 5 or 6. They were some of the earlier patients in the practice we were working with, but intervening early helped. The issue is when you go to the gym with the trainer for a year, if you don't use those muscles properly for 2 to 3 weeks, you lose it. That's soft food. It can
Right.
be that quick. So most parents start to get, oh, wow, even if I give them a good start, I could lose it with soft mush. An apple squeezer is not the
Hmm.
same as an apple.
Right. Right.
Yeah.
Well, I mean, one could be tempted to say, well, if it's this prevalent, isn't that just part of evolution? And why should we really even care if they're, this malocclusion and I'm going to get braces and, everybody has some teeth issues. So what's the big deal? But it is a big deal.
It
There
is.
are lasting consequences of not addressing this. So what are
Yeah,
some of those, Ben?
sure. So the immediate thing that we've been talking about is like, oh, crowded teeth. You see
Right.
crowded teeth in a bad bite, and most people are going to think, well, it's not sightly. We want to look that way. We want to have a nice smile. And we're talking about the aesthetic category. But there's a much bigger issue going on. When we have those crowded teeth, it's because of the underdeveloped jaws. But the upper and lower jaws, it's their development that establishes how well we're going to breathe.
Hmm.
So the upper and lower jaws, when they grow fully, we get a better breathing space. So loosely in dentistry, we call this our airway.
Right.
A human being is an obligate nasal breather. So, as an obligate nasal breather, it's your only possibility to deliver the oxygen and balance all the ingredients that fuel a human being is coming through the nose. The nose prepares the air perfectly for the lung to do its job, so the system runs really well. But once we start to mouth breathe, we've got problems. So, here's the bigger issue. When the jaws are too small, the upper jaw is what builds the nose. So, for air to flow through the nose nicely, we want a big, properly grown upper jaw. When the upper jaw is too small, the nose inside is too small. So, to have something, a visual, it's the difference between breathing through a coffee straw, the coffee stirring
Right.
straw, or a garden hose.
Right.
You want to breathe through a garden hose. Well, the only way you're going to get that garden hose is if your jaws grow fully. Now, the upper jaw builds the nose. That's the starting point. But when the air goes in the nostril, it has to turn around and go behind the tongue to get into the lung. So when the lower jaw is too small, because both are too small, upper jaw too small, can't breathe well through your nose. Lower jaw too small, there's no room for your tongue. Now, when your jaws are
Mm.
small and your teeth are crowded, your tongue has less of a parking space or a home. So instead of the tongue being high and forward, it's back. And when the
Mm.
crowded teeth deliver the tongue back, it blocks the air. So now when you can't breathe well through your nose, you have to open your mouth. It's compensation. But the moment a child opens their mouth and breathes through their mouth, now the air comes into the lung differently. So I teach parents the difference between nose and mouth breathing because they're not similar. They're
Right.
opposites. These are as two opposite of things that as you can get to describe nose breathing and mouth breathing. Nose breathing, the nose was built to prepare the air. It filters it, cleans it, warms it. It's got like 40 functions on that air before it even gets near the lung. So the air is prepared by the nose, gets in the lung. Now the lung can do its job correctly because the air is proper. The lung is the exchanger. Get the good
Mm.
stuff in, get the bad stuff
Right.
out, basically exchanging, right? When the air comes in the mouth, nothing is done to prepare it. It makes it to the lung. I like to describe mouth breathing as your body's CPR.
Mm.
It's just protecting you because your nose isn't working well. If you can't breathe through your nose well, your body opens your mouth because otherwise the consequences are bad. So
Right.
your body's opening your mouth to let air leak in to save you, not fuel you. So
Mm.
I talk to parents about elite sports cars, race cars. If you're going to get on a track with an elite race car and do a big race, that car requires a certain fuel, and they are grades of fuel. So you want to get on the track with like a Ferrari and race and win,
Right.
you get the right fuel in it. Well, that's nose breathing for a child, proper fuel. Now, if you put regular, everyday average, low grade gasoline in a Ferrari and put it on a racetrack, you'll go around the track. You're not winning that race, and that car will eventually malfunction. That's mouth breathing. Mouth breathing is putting in the bad fuel into a child,
Right.
and then the consequences downstream are huge because the difference between the nose and mouth breathing is that now your body is working off of the poor air coming in. Your lung doesn't make the
Right.
same exchange. You're fueling yourself differently, and that creates the symptoms downstream, which are endless. A list of symptoms from mouth breathing, day or night or both. Mouth
Right.
breathing does not have to be 24/7. It just has to be a little bit of the day or night or both. And as soon as a child starts mouth breathing, welcome to unhealthy symptoms that are coming downstream.
And one of the sort of negative consequences of this underdeveloped jaw that I came upon too. Not that we need any more than you just listed, but you talked about the personal one of wanting to appear your best, but there's also issues of social acceptance that I learned about that people with underdeveloped jaws can be perceived by society as less intelligent. So they are just afforded fewer opportunities. That's a strange consequence and far less probably important than the physical consequences, but that's out there too. So there's just this host
Yes.
of negative consequences of leaving this issue unaddressed. So
Yes. It's a great point you bring up.
the the other piece in kind of preparing for our call though that I discovered is there are a lot of different people kind of promoting different ways of addressing this now. So help me understand how I should, if I'm a consumer and I'm looking to have my infant first assessed, what does that involve?
Right.
And then second, what sort of solutions or might be proposed if I'm that parent?
Oh, sure. So early on, if we're in infancy, one of the things to take a look at would be what are called tongue tie, lip tie,
Mm,
or cheek tie. So those are things that can be helped early that can help with breathing and then, of course, nursing and sleeping.
yep.
So looking at that is something early. So that's kind of like, okay, after birth, if we're struggling, the indication usually is if there's a difficulty with the nursing. So if it's painful and or not productive, there could be a tongue, lip, or cheek tie preventing the muscles from behaving properly to
Okay.
earn the milk. Now, if that's addressed early, that's one thing that can help an infant to then nurse properly and grow a little better. So that's an early one. After that, there are opportunities in the food category, because certainly here I just said, well, the early soft food,
Right.
which begins very young, try to stay away from purees, but that doesn't mean you give your kid a lump of beef jerky. We have to be careful. And so there's a pathway. And since the babies don't come with an instruction manual, there are two places to learn more. If it's okay with you, I would mention them. I don't receive any
Yeah,
benefits or
please.
compensation, but they're educational for parents. One is baby led weaning. And
Okay.
baby led weaning, Weaning, it's a book. Jill Rapley, Tracy Marquette wrote this beautiful book, but they also have social media or Instagram and followings. Baby led weaning is like an instruction manual. How do I introduce solid foods to my infant earlier?
Mm,
So then we're learning how to do that as opposed to just trying it, right? The other one is called Solid Starts. And Solid Starts is out there. They have a wonderful Instagram following and a beautiful instruction manual on how do I introduce what's the right way to introduce solids to the different ages, because the kid is going to
hmm
grow from 0 to 3 years. During that time, if you intervened with checking for tongue, lip, and cheek ties, that's a good thing to check for early.
hmm
Then working towards education where you learn how to introduce solid foods at the correct ages and what it might look like. And those are two directions where I've learned, and I know there are more, and I feel bad for not knowing every one of them. But those are two that I know of where parents can seek education. Then you're kind of heading in the right direction to have more natural diet going. That
Okay.
helps the muscles in the jaws grow. But you might turn 3 years old and not have done this, like I did with mine, with all the wrong stuff early. I would we blended it up till the blender caught fire because you don't know what you're
Right.
doing, and you're like, well, how soft does it need to be? Well, I think if the blender's on fire, then it's soft enough. That's how we knew.
Right.
Just keep the blender going till. Anyway, what we did was started. And so at 3 and above, there are different ways to go about helping a child. Now, one of the categories, and these are things that we began in our office a while ago, they're called guidance appliances. Well,
Okay.
guidance appliances are soft and comfortable and easy to wear, and it looks at a glance like a football mouth guard. It looks like something you'd
Okay.
put in your mouth and go play football in. But meanwhile, its design is so that it guides the musculature of your jaws to behave properly. So when you put a guide for a child who's 3 and above, and from 3 to 11, these guides exist in different shapes and sizes depending upon
Okay.
how it's not a one size fits all, obviously. The different shapes and sizes are for the different age groups as well as the different teeth that are present. So once you know what's
Mm,
there and where the child is, you select, oh, yeah, this would be for you. Now, when they wear the guide for an hour a day and overnight, what happens is that when the guide's in the mouth, it redirects the tongue to swallow properly. So one
okay.
of the things happens with the softer food is the tongue learns to stay lower instead of higher. So softer food is more drinking technique than it is chewing and compressing. So the
Got
tongue
it.
doesn't work like a piston up and down kind of thing. There's no compression. It's really just swallowing by drinking. Now, the guide directs the tongue to the roof of the mouth, which helps jaw growth out and forward. But the guide also pushes away the lips and cheeks a little bit so that the jaws can go wider and forward instead of having the lips and cheeks working against us coming back.
Oh,
So when the tongue gets softer food and it's only swallowing liquids, the lips and cheeks start to activate and work more to help push the liquid down. So it's a common look that a child will chew with their mouth open,
hmm
chewing with the mouth open, but when they go to swallow, they close and they use their lips and cheeks like squeezing a little outside. So it looks like they're forcing a swallow. Well, if the outside is hyperactive or works more and the inside is weak, that's going to be bad growth. That's bad for growth.
Okay.
So the guide redirects the muscles. It flips the script. Let's get the tongue working right and let's get the lips and cheeks out of the swallow. So guides are helpful. The second thing that's helpful is myofunctional therapy. So the full title would be orofacial myofunctional therapy. Basically, these are specialists in our community
hmm
that more and more, there's a growing profession. Every child needs one, basically. If you have poor muscle use, you need one. But a myofunctional therapist can work with a child. And That's basically to redirect the breathing, the muscles, and your posture to be correct. And when you have all those things lined up, your jaws grow better. So getting basically working with the musculature to get it functioning properly, strengthened properly, you can have your jaw growth back. So guides to wear,
Hmm.
myofunctional therapy, and nasal hygiene. And nasal hygiene is a lost piece of the hygiene in today's society, especially in little kids. They just run around sniffling and wiping it on their sleeve. But we have to blow our nose, and we need to use some natural nasal sprays a few times a day to keep that nose clear. Because once we do have the early soft food and the jaws are too small and we're not breathing well, the body is a use it or lose it type of mechanism. Like we talked about how the muscles go away when we don't
Right.
use them. When we don't breathe through our nose, it actually closes off on the inside. It starts to close down. So we have to earn the nose breathing back. So we have to combine three things in the office: the guides to wear, the myofunctional therapy, and the nasal hygiene. Now, combining these three things can help a child redirect their growth. That's the least invasive way to go. Older you get, the farther behind you get, the more crowded teeth you see. We have to start incorporating expanders. So
Hmm.
expanders exist at a little older age to go forward. Mostly I'm trying to avoid expanders because I like to get in earlier. If we get in earlier, we catch up, we avoid those. But if we meet the child at 8, 9, or 10, sometimes we need expanders first. So expanders exist. We're basically trying to focus on all of the things we offer are really to focus on using the jaw muscles correctly to regain the proper growth of the jaws so that the teeth can eventually land where they belong. So what we're doing in the office is intervening by 3 or above whenever we meet the child so that we can help that child grow the jaws, get their breathing back. And the
Yeah.
one step more we didn't get to yet, but we probably will, is that when your jaws are too small and you're breathing through your mouth poorly, it does affect your sleeping.
Yeah.
And if you interfere with the quality of sleep, you're going to have an unhealthy child from that. So the ultimate outcome of having smaller jaws isn't like you mentioned, where the crowded teeth, that's not so bad a thing. Really, the poor breathing disrupting your sleep. Sleep is critical for health. And if
Hmm.
we have poor quality sleep, we're going to be experiencing a whole host of other symptoms from that. And that's where the behavior and the bedwetting and the ear infections and the digestive issues and the cognitive issues. I know you brought up and mentioned cognitive. It's not just a perception that mouth breathing is unsightly and might
Hmm.
be more of that look that is associated with. It's actually been proven in the research that the kids who have poor breathing while they're sleeping
Right.
have lower IQs.
Right.
So that's a real thing.
Well, and as I'm thinking and I'm hearing about your approach there, is there a downside? So if you're, is there a downside to teaching the mechanics of good posture and good breathing? Is there a downside to introducing some of these appliances at age 3? I mean, well, it seems like this could work if you were at a serious risk or if you were at lesser risk. I don't see what the damage would be
Right.
to doing these, to having these practices, the introducing of the hard food, the potentially using an appliance to give that space, and then also like developing the mechanics of healthy breathing and healthy posture. Am I wrong? Am I missing something here? Is there somebody that this would be bad for? I guess is what I'm asking, Ben.
No, there's no negative whatsoever. Because
Right.
again, the things we're describing, wearing a guidance appliance, well, that's only redirecting your muscles to behave appropriately.
Yeah.
Nothing negative can happen when your muscles are guided towards behaving appropriately. So you're doing only a positive there, no negative. Myofunctional therapy, again, is with breathing, musculature, and posture.
Yeah.
You're only guiding a child to have proper breathing, nasal, and then musculature activity of the jaws, and then the posture. So you're only doing things that could benefit. And nasal hygiene can only benefit you. Cleaning your nose out, there's no negative to blowing your nose. And I like to say natural sprays instead of pharmaceutical ingredients, because
Right.
those we shouldn't have on a daily basis for extended periods of time. So if you're using like a simple saline or something that's natural, you can use that a couple of times a day and clean your nose nicely. So there's no negative. The who benefits, like you mentioned, is it a mild problem, a moderate, or a severe? Well, any child can have this technique, whether they have mild, moderate, or severe malocclusion
Hmm.
and bad bites, right? Or mild, moderate, severe crowded teeth, mild, moderate, severe symptoms. At any point, you can intervene early. The biggest downside comes from not having the opportunity, and then you turn
Mm.
12. Because
Hmm.
once you turn 11 and 12, you have no chance to do something that you needed between 3 and 11. So between 3 and 11 is nice, but if you turn 12, I can't do these things as well because now the bone is more mature. it takes us out of the foundation category, and now we have to address the teeth most likely. So 12 and above, the risk of missing, the only negative is in the compliance category. So you can't hurt a child by doing these
Hmm.
things. You could only improve them. The level of improvement comes from the compliance, because most people who are listening to this will understand, well, wearing a guide for an hour a day and to bed, well, it's removable. Yes, it's removable.
Yeah.
You wear it for an hour a day, and then blowing your nose, that's on you. You have to blow your nose a
Right.
couple times a day. Exercises, if you get to a myofunctional therapist and they teach you some exercises, well, then you continue them. You get the homework. They ask you to do a few things every day to keep it rolling, right? So we talk to parents about it's like a gym membership. It works if you're there, if you go to the gym, but
Yep.
if you just let it ding your credit card and you don't go to the gym, we don't see the results on our body. So the worst possible outcome of this is that you start and don't keep up with good compliance, you don't get the results.
Right.
You have to do the work to earn this, and that's in any category, whether we're talking about early
Well,
food, learning and
exactly,
doing.
exactly. I mean,
You got
this
to
is not
invest.
exactly, and anybody. I mean, again, if you paid attention to the literature or to even to this podcast, you know that starting early makes habits easier to form, right? So, and you want to be modeling these behaviors as well. So, if you are demonstrating a regard for proper dental hygiene and also proper physical hygiene and posture and physical health, your child is much more likely to pick up those habits. And that's across the board. So we know that that
Yes,
is. So I've got this one thing that I'm kind of worrying about here, Ben. By the
sure.
way, you started to touch on apnea. Um, Apnea in kids is kind of what first got me interested into this issue of
Mhm.
underdeveloped jaws. And as we were discussing, I had your colleague Blaine Leeds on, and so listeners can go back and listen to that episode because that's all about apnea, and how terrifying it is if your child has it, and the consequences, the cognitive problems that result from that. So you can go back and that because that really does deserve a much longer treatment than we can afford in this particular
Yeah,
episode.
your
But
audience is going to like that one. That's a good
yeah,
one.
I think so. He was a good guest, just like you. The when I'm hearing some of these, uh, your analogies, but also um, to me, I'm seeing parallels with some of the special training that some kids get for sports. And so nowadays, that if you decide that you want your child to excel at a sport, there are programs and paths that you can start them on from day one, right? You can bring in the specialists and you can bring in the trainers and you can sign them up for all the leagues and get them the best equipment. What I worry about with that is those are things that are typically only available to families that have a lot of resources. So these techniques that you're describing, these interventions that you're describing, um, are they things that if I'm somebody and I have just a basic medical and dental insurance, do I have access to this, or is this going to be really expensive to me? Is it being accepted as a necessity so that it's getting covered by more plans? Or where does it stand in terms of out of pocket expenses, Ben?
Yeah, so there can be insurance coverage for these types
Okay.
of techniques at any age. And then on top of that, the bigger issue is that they're less expensive than getting like traditional braces or things that
Okay.
are more involved later. So the interventions that are done earlier tend to cost us less. And yes, there are opportunities for insurance coverage. The good news is that earlier treatment helps treat the cause versus the later treatment
Right.
treating the symptom. You're going to get more for your investment early on versus later, where you're going to have the teeth shift back. So we have to
Right.
repeat it. But back to the apnea, just one quick word on that. And I know when
Yeah.
your listeners listen to Dr. Leeds, and that podcast is amazing, they're going to like that a lot. I'm only going to share a little bit of the analogy I go with the parents
Hmm.
on apnea, in that it's actually a small percentage of kids will actually have an apnea diagnosis. So sleep apnea is the worst breathing that you could have.
Right.
So for parents to kind of get this, I want to share this analogy. So sleep apnea, it's the worst breathing you could have. We're going to make that analogous to like a stage 4 disease.
Okay.
So stage 4 disease is the worst you could be. Sleep apnea is like what it does is it makes stage 1 mouth breathing.
Mm.
So now if stage 1 is mouth breathing and stage 4 is sleep apnea, you don't just become sleep apnea overnight. It's not a light switch. It's a chronic deterioration. You have to kind of graduate to it. Some kids will have it, and I think the estimates are about 3 to 5% of kids might have sleep apnea. That's a low number. But what I'm saying is you've got 99% of the kids have underdeveloped jaws because it's a unicorn that has full jaw growth. So if we've got 99% in the malacclusion or crowded teeth, bad bites, underdeveloped jaw category, you have that mouth breathing as an almost immediate result of that. So the moment you see your child is mouth breathing day or night, even a little bit, we have an unhealthy child that has symptoms there. And so now you've got your stage one. So the whole part about where parents get told, oh, that's normal, they'll outgrow it. There's nothing to do early. Don't worry about that. That's not a thing. You're going to do it later or whatever. That's all wrong. That would be like telling someone where if you showed up to a doctor and they said, oh, you have a stage one of this disease, come back when it's stage four. You'll be okay.
Right.
We could treat it at stage four. No one wants to wait to treat a mouth breathing child till they're stage four, which is getting sleep apnea. So the disconnect is that when a parent takes a child for a sleep study, again, only 3 to 5% are going to come back with apnea. So you go to a sleep study because you think there's something wrong with my child's breathing and sleep, and they tell you, you don't have apnea, you're fine. You're not fine. You just don't have apnea. You don't have stage four. You're in stage one, maybe two. But your early problems have the reasons. Again, snoring, waking at night, night terrors, sweating at night, bedwetting, ear infections, behavioral issues, whether it's at school or at home, the hyperactivity and all this distracted, unfocused attention issues. All of this is related to poor quality of sleep. So, yeah, the mouth breathing is where this problem begins. So, do not accept your child. That's normal. It'll grow. You'll grow out of it. Nobody's outgrowing any chronic illness. You don't outgrow this. So, you need to address it early in order to have a healthy child. Otherwise, what we say in our little circle is that if you don't treat the cause early, you will treat the symptoms forever. That's where this goes. And so get in there at mouth breathing as early as possible. Don't wait until you have an apnea diagnosis. Most people are going to get their apnea diagnosis when they're an adult. But your adult sleep apnea began when you were a child with your crowded teeth and your bad bite. And one of the telltale signs is that list of symptoms I kind of keep rattling off. If your child is mouth breathing at night or snoring, if they are bedwetting, if they are having nightmares, if they are night sweating, if they're waking at night, not sleeping through the night, if they're restless, thrashing around, if they grind their teeth. These are all the symptoms in sleep that are unhealthy. Those are what are leading towards all the systems that malfunction. So now we have cognitive issues, neurodevelopmental issues. We have the physical issues. We also have the digestive issues. We have the cardiovascular issues. We have any system in the body is going to be affected by poor quality of sleep. And it's the breathing that is the most related to the quality of sleep.
Ben, if there's somebody listening to this and they feel that this is really resonating with them and they like your approach, if they wanted to connect with you and colleagues who have undergone kind of a similar education and training, how can they do that?
So, based on the couple of decades of treating patients in my office and others like me, even though we're few and far between, we're out there. But about 3 years ago, we put our heads together to build something that would solve for access so that anyone anywhere could recognize this and be treated wherever they are. Number one. Number two, affordability. Build something that was more affordable for parents. And that's how Toothpillow was born. So the parent who wants to learn more and kind of pursue, is my child a candidate for early treatment? You would go to toothpillow.com. And toothpillow.com is where you can see a lot of information. All the things we're talking about, it's built into a website that is educational for parents, making all the connections of the smaller jaws to the poor breathing, to the poor sleeping, to the symptoms. And then, of course, what the opportunity is to treat the child. Well, the three things I described, using guides, myofunctional therapy, and nasal hygiene, that can be done remotely. So we built Toothpillow as a model where when a parent submits the information, we go through a questionnaire. So we learn all about the child's symptoms and their history. What are they struggling with? We have them upload with their nice smartphone the photographs of their child's teeth, bite, profile, face, because we can see it. And once we know it's there, then we have also proprietary rulers that get sent. We can measure. We know what to send you. So a parent could submit their child, then I get to review it. So myself and other people who have a ton of experience review that child. Are they a candidate to be treated remotely, which solves the access issue in case there's no one near them? Now, the first level would be if there's an airway dentist near you, that's fantastic because then you've got someone who's doing growth and development on kids between 3 and 11. If they're doing it in their office, they could show you the cases, who they treat, how it goes. Then you have someone local. It's rare that someone is local, where there's not enough of us yet.
Hmm.
So Toothpillow was built to solve for access, meaning instead of having to fly to New York and see me or go several states away to find someone who does this, you can go online. I can give you a breakdown between 3 and 12. Between 3 and 7, it's about 99% of the kids are possible to treat remotely. We can send you what you need, and then we monitor you. So we have a team of about 50 support members that manage the parents daily, weekly, monthly. We have another team of about 75 doctors who represent all 50 states, and we oversee the treatment. So now we have treatment being overseen by professionals who do this. And sure enough, we can monitor that child over time and get them the right guides they need. Myofunctional therapy can be done via Zoom, like we're doing. We're talking to each other. You can model the exercises and do that online.
Mm.
So Toothpillow was built to help a child anywhere have access to something at an affordable cost. It's a lot less to do it remotely than it is to show up in an office. You take
Right.
away the building, and next thing you know, you have a fraction of the cost. So toothpillow.com is where we ask parents to go. 3 to 7 years old, it's almost all of them. 99% can be treated. But 8 to 12, that number drops a little bit. We can only treat about 2/3 of the kids remotely between 8 and 12 because this, again, is guides and myofunctional therapy and nasal hygiene, but not expanders. Expanders are not remote. So if I recognize from the submission, oh, this child is between 8 and 12, but they really need expanders,
Yeah.
we don't just reject you. What we do is we then guide you who's near you because we have a nice locator built, people who are trained to intervene with expanders and do a beautiful job to help your child. So from 8 to 12, if I have to that 1 out of 3 kids who can't be treated remotely, we like to guide them towards an office near them where they will be treated very well without a tooth focused approach, with a basically a foundation focused approach. Let's grow
Foundation.
your
Right.
jaws first. So we do like to make a referral for the ones, but 2 out of 3 8 to 12-year-olds can do this remotely and do a wonderful job. So that's been the last 3 years. We beta tested it, we built it out. We now have several thousand kids in treatment nationwide, and they're doing very well.
Well, Ben, I want to thank you so much for taking this kind of upstream foundational approach. I wish you all the luck, and thank you for being such a great guest and coming on talking about kids.
Oh, I appreciate it. Thanks for having me.
That was Ben Miraglia. More information about Ben, including links to Toothpillow and the books that he mentioned, is at talkingaboutkids.com. And when you do visit talkingaboutkids.com, let me know what you think. I read all of the feedback. The Talking About Kids theme song is by the Senators. For more of their music, go to thesenatorsmusic.com. And remember, kids are young goats and young humans. And the difference is that young goats are easier to manage.